to an in-person academic council, and maybe even by our next meeting in October, but we will keep you posted on that. I would like to begin by welcoming all the new members of the Academic Council. Welcome to your first meeting, and also to all the returning members. I want to begin by acknowledging our former chair, and I hope Carrie is here, Carrie Haney, who had served as the chair of Academic Council for the last 2 years during these unprecedented times. And I really want to thank him for his leadership and really demonstrating to all of us the importance of Duke's shared governance. I also want to note at the end of the last Academic Council, someone said that Carrie leaves some big shoes to fill. So I am only slowly stepping into those shoes. The Executive Committee of the Academic Council, otherwise known as ECAC, has been meeting weekly since the middle of August. And I want to take this time to also acknowledge the members of ECAC. We have 3 new members who are starting the first year of their 2-year terms. The first is Keisha Cutright from Fuqua School of Business, Scott Hutel from Psychology and Neuroscience, and Thea Portier-Young from Divinity. We also have 4 members who are returning for their second year. The first is Laura Lieber from Religious Studies, Divinity, German Studies, and Classical Studies, Joel Meyer from the Nicholas School of the Environment, Manoj Mohanan from the Sanford School of Public Policy, and Ann West from the School of Medicine and Neurobiology. And I want to thank all my members of ECAC for their service too. According to our bylaws, ECAC must select from the Executive Committee a member to serve as the vice chair. And Manoj Mohanan has agreed kindly to serve as the vice chair for this year. Lastly, I want to acknowledge 2 people who keep ECAC and Academic Council running at all times. The first, many of you already know, who is invaluable. That is Sandra Walton, who is the executive assistant to the council and ECAC. And then we have a new hire, a new staff assistant, Mariah Cook, and we welcome Mariah to her first Academic Council meeting. So a few ground rules for Academic Council. Attendance is taken at all meetings. For those of you who remember when we met in person, we pass around a piece of paper, you initial it. But for these meetings that are still on Zoom, attendance is taken through the portal. Our bylaws state that you can be removed from the council if you have 3 consecutive unexcused absences. And I'm sure no one wants to be removed. So please email Sandra if you are unable to attend a meeting. And as you ask questions or make comments during Academic Council sessions, please say your name, your school and department or department. So our this is largely because our meetings are recorded and then transcribed. ECAC and I always welcome suggestions for discussion topics for future council meetings. And if you would like to suggest such a topic, you can email me directly. You can email any member of the Executive Committee, or you can send an email to the Academic Council email account, and that is acouncil@duke.edu. The council also has a tradition of submitting questions to be asked anonymously of any one of the senior officers, be it the president, the provost, or the executive vice president. You can do this again by submitting an email to the Academic Council web email, or through our website at the Contact Us tab. So for the first agenda item, you should have received in an email this week a note about the Faculty Hearing Committee. At the September Academic Council meetings, we approved the new members of the Council's Faculty Hearing Committee. And on that document that you should have received was a list of continuing members, and then also the new proposed members. We received no objections or questions regarding the 7 new members. And as such, these members are considered approved. I would like to thank all the members who are serving on the Faculty Hearing Committee, all 17 of you, for your service and future service. I would also really like to thank, a special thanks to Trina Jones from the law school, who has agreed to serve as chair. Trina has been an active member of the Academic Council. She is serving on it now. She has been a member of ECAC. And thank you again for taking on another role in your service to Academic Council. We hope this will be a quiet year. And we also want to thank Sam Buell from the law school, who has also served as the chair for the last 4 years. Okay, so if you're like me and you're wandering around campus, you've seen a lot of activity, a lot of tents, a lot of noise, and if there is some noise, it's from outside the Academic Council office. And it means commencement for the class of 2020 is happening this weekend. But I also want to draw attention to another event that is happening tomorrow at 5 o'clock, in which the entire Duke community is invited to, and that is to attend the public ceremony for the dedication of the Sociology Psychology building for Wilhelmina Rubin Cook. Wilhelmina Rubin Cook is from the class of 1967, and she was one of the first 5 Black undergraduate students at Duke. And so I encourage everyone to join in this celebration of her remarkable life and career tomorrow again at 5 o'clock. For our first, the main agenda item for today is hearing from Duke's modeling team as it relates to the pandemic. But before we turn it over to the modeling team, I want to ask President Price to say a few words, to introduce, this is the start of the academic year, and just to hear from President Price. So I don't see you on the screen, but the screen is yours.
Thanks, Erica. I am here. Lots of tiles, lots of pictures on our computer screens, I know. And I would just like to thank you, Erica, for your leadership of council, and thank all of you with us here today. I also look forward to getting together in person. And I also encourage you, if you have the opportunity, to join us for the dedication of the Rubin Cook building tomorrow afternoon, and what I expect will be a lovely commencement, a long delayed commencement ceremony for our class of 2020 on Sunday, if you're able. I just want to thank all of our faculty members for extraordinary commitment during the pandemic. We're just so grateful for all the many ways that you've gone above and beyond over the course of the past year and a half to ensure that Duke can continue our commitments to teaching and discovery in what I know are very complicated times. I realize this has not been easy. In fact, for many, it's been among the most challenging of times we have faced. I certainly understand the frustrations of faculty who had to deal with that, sudden transition to remote learning in the spring of 2020, which now seems to so many of us as if it were in a different decade. That, of course, was followed by all the uncertainty and the challenges of teaching last academic year. And now, although we're gathered together on campus again, we have the continued operational disruptions and the health concerns that have faced us this fall, thanks to Delta. And yet I know that our students just so appreciate the opportunity to be here in our classrooms. And I'm aware of how much they need, more than ever, really, this opportunity to learn from and study with our distinguished faculty, and how much it means to our wider Durham community that our health system and our university both have remained fully functional throughout the pandemic, while working hard and in very close collaboration to support and protect our wider community. So as Erica said, we have today assembled a group to brief you on our COVID modeling and our ongoing COVID management plans and protocols. And we have with us today a few of the architects, really, of our response. We have Dr. Tom Denny, professor of medicine, who along with his colleagues in our Duke Human Vaccine Institute has been absolutely central to developing and implementing our extensive testing programs. Dr. Cameron Wolf, who is associate professor of medicine, who's lent generously of his time and his expertise in infectious disease to help us develop our protocols. Dr. Steve Haas, who's professor of biology and also on the faculty of medicine, who's been central in our key ongoing modeling efforts, and Vice President for Administration Kyle Kavanaugh, who has, I will say, seemingly been everywhere all the time in leading our COVID management activities. So I am incredibly grateful to Tom, Cam, Steve, and Kyle, as I am to the dozens, indeed hundreds of other faculty and staff across campus who have been instrumental in keeping us safe while we teach, learn, discover, and serve. Thanks to these impressive team efforts, and they really are team efforts, our COVID protocols, disruptive as they have certainly been at times, they've allowed us to keep moving forward. And despite the renewed challenges of the Delta variant, we're in a significantly better position this fall, certainly compared with last year. Duke is fully vaccinated with very limited exceptions, which enables our university community to remain active and engaged and to be here together and in person. The life of our university goes on and is still vibrant. Importantly, our policies are also intended to help mitigate viral transmission and thus to safeguard the wider community in which we're living. Over the past several weeks, as you no doubt are aware, North Carolina and the Durham region, as with many parts of the country, have been dealing with hospitalizations at rates that are close to the highest seen since the onset of the pandemic. And the good news is that cases may be cresting, but we really can't afford to compound any ongoing public health challenges. Now, fortunately, because our faculty, students, and staff are vaccinated, the great majority of those in our community who are infected have been asymptomatic. None have been, seriously ill. However, while infected, they can and they do transmit the virus to others. And thanks in large part to the testing and quarantine protocols we have brought our student caseloads down from over 350 in the first week of September to fewer than 20 last week. And that's out of more than 21,000 tests conducted in the past 7 days. So these protocols do work. We understand well that mental health is also a vibrant and vital part of our public health commitments. We do what we can to support the well-being of our students, faculty, and staff during all these disruptions. And to that end, we are carefully studying, in particular, whether isolation periods for infected but vaccinated individuals might be reduced while safely limiting viral transmission. So the evidence suggests that our policies are working. To be sure, we're not out of the woods. And we continue to work on a daily basis, indeed an hourly basis in many cases, with our public health experts and senior leadership across the university, with our faculty and staff, to design interventions that will keep us safe and on a trajectory toward normal operations. So I want to ensure that we have plenty of time for questions. Let me just say again, thank you very much for everything you've done. I'm just so grateful for everything that you're doing for Duke. I'm proud to call you my colleagues on academic council. And Erica, with that, I will either hand it back to you or hand it over to Kyle, whichever you'd prefer.
Thank you. Thank you, Vince, for also just providing a perspective on the start of the semester. I know many of us were expecting a different start to the semester and have had to learn to be quite adaptive, especially in a situation where there's been lots of uncertainty. And it's because of that, we really wanted to hear from the modeling team today to really understand the data and how decisions are made, that shape, how we're in the classroom, how we're on campus and back within university life. So I'm going to turn it over to Kyle to guide this discussion today, and then we'll come back for Q&A. So again, if you have questions, raise your hand and we'll put you in the queue to have them answered afterwards. So Kyle,
Erica, thank you. Good afternoon, everyone. I hope everyone is doing well. The way that we've structured this is I will start with laying some groundwork of the planning that went on through the end of the last academic year, the summer. Then to the start of the semester, share some data with you, a variety of experiences that we've had. I'll then turn it to Steve, and he's going to go a little bit deeper into some of the analytics and the structure of the modeling approach that has been used over the last year. Steve is also going to say a word or two about some of the sequencing experiences we've had. And then we'll turn to Tom, who will go a little bit deeper into what I would label as some of the unique aspects of our testing program here compared to many other schools around the nation. And then we'll wrap up with Cameron, who we've asked to talk a little bit about transmission, but also I'm sure everyone is paying very close attention to what's going on with both the FDA and the CDC as it relates to boosters and also beyond for children as it relates to the vaccine. I'd also like to just extend my appreciation to faculty colleagues who have been absolutely invaluable, certainly to me personally, but I've labeled it as the Duke difference, the reliance on some of the people that we have here today, but there are dozens of people that have been actively involved who have been incredibly helpful. Steve, if we can move to the next one, it really starts with just laying out kind of a framework of what has continued to be a growing reliance on not only people and expertise, but a lot of data. So in addition to our own modeling team, we've continued to expand the individuals that we're relying on, from Mark McClellan to Dennis Clemens to colleagues over at DKU, and certainly on an absolute daily basis, our close working relationship with the health system. We also, which we shouldn't take for granted, is not the case everywhere across the country, have strong working daily relationships with Durham Public Health, with Rod Jenkins, with Zach Moore, who is the state epidemiologist who we're in very regular contact with. We're incredibly fortunate. We've both been invited to and have had ongoing conversations with the CDC. We have standing meetings both with public and private universities, not only here in the state, but we have weekly standing meetings with all of our peers. So we're comparing all of that data. And at Duke, we have some unique opportunities to have access to, for example, some of the professional sports leagues like the NBA, and have talked to them about protocols and approaches. Dr. Wolf also has unique access to not only nationally at the NCAA, but he's chaired the ACC Medical Advisory Committee. And finally, we're looking at all types of data, not only our own, but also certainly from Hopkins, the CDC, state, and many others. If we go to the next one, Steve, this is really the start as we came out of the spring going into the summer. We had very strong advocacy, and we'll show you some numbers here on what's going on with vaccination, but looking at using these models and going into about the middle of the summer, which I will tell you was a very challenging time, because if you remember, we kept our testing program going through the summer. We're doing about 4,000 to 5,000 per week, supporting our research initiatives. But we were seeing very, very low numbers. And I think there was a risk there internally for us to get lulled into a sense of complacency. Thank goodness for the work that was going on in the modeling, taking a look at what was happening in India, in Israel, in the UK, and looking at some early emergence of some of the variants. And that's really what drove us to then have a very robust testing program for the start of the semester. I will tell you, compared to our peers, that was a lonely position for us to be in during the summer. But we did start with entry testing. We'll keep our surveillance. We'll talk a little bit about our sequencing piece. We did plan to have approximately 150 isolation beds at the ready, but we also had a plan B, C, and D, which was what would happen if we saw some really increased quick spikes, which we did in week 3 that we'll talk about. Obviously, supporting our in-person instruction, knowing that we were going to have a large number of humans here, both undergraduate and graduate, ensuring that we can keep the research enterprise moving along, and then supporting in-person football and other types of athletic events. If we go to the next one, I'm very pleased to kind of share with you This time last year that we started the planning, working with our health system partners about the rollout of the vaccine. If we go to the next slide, this is something I think each one of us should be incredibly proud of. This is data from this morning. So as of this morning, both the health system and the university were over 43,000 faculty and staff that are fully vaccinated. Our entire student population is fully compliant. We are north of 16,000 students that are fully vaccinated. So we have close to 60,000 people that are in our community that are fully vaccinated. If I just look at the university itself, this is from this morning, we're north of 22,000 of our faculty and staff. So we're over 95% that are fully vaccinated and 98.5% that are fully compliant. This is really a spectacular accomplishment. Now into the data of what we've seen over the first couple of weeks. This is our positivity numbers that we've seen starting in the week of August the 2nd. That first week is a little bit of a misnomer because we really had very small populations. This was a return of our School of Medicine, Fuqua, others. But then if you see the blue are student numbers, the orange faculty and staff, and the faculty and staff numbers have stayed fairly stable through this entire period of time. But you see that we were a little bit higher than we had hoped for in weeks 2 and 3. And that gave us a lot of concern and triggered in terms of a number of things that we were looking at all kinds of variables here, not just the number of cases, but the severity of that. So we're looking down into the viral loads of each individual case. We're in contact both internally and externally about that. And going up on that ramp, it really spawned 5 different things that we did. One was to dramatically increase the amount of isolation space that we had available. Second, as we were thinking about week 5, dramatically increasing the frequency and the targeting of the surveillance testing. As you know, we did some modifications to external wearing of masks, some modifications of dining, and then the curtailment of some of the large events that we had. If we go to the next slide, Steve, these are really difficult to show cause and effect, but I think that we were comforted that all of the things that were put in place there, and a lot of credit to our undergraduate and graduate students who complied incredibly well here, that we saw a very quick reduction in cases in week 5. And if we go out to, Steve, week 6 and 7, you'll see that those trends have continued. We're expecting that we're probably going to see a little bit of a bump here and there as we continue to go on. The couple things that I would say is virtually this entire population, nearly 100% fully vaccinated. The majority of these cases are either asymptomatic or have very, very mild symptoms. So it's been a good experience so far. If we go to the next one. I mentioned earlier that since the beginning of the year, we've been working with the NGS lab, and we have been taking every single positive and going through sequencing. Steve's going to dive into this in a little bit of detail here, but I wanted to point out a couple things. The slide is color-coded based on the type of variant that we're seeing. And if you see kind of going back into the beginning of this, this was all what has been referred to as kind of alpha variant. If we get into that kind of yellowish in there, that was the first outbreak that we had back in March. And this was all California variant that we see. As we go through the summer and you get into that orange, that is now all the Delta variant. And we have seen 100% of Delta. We'll see some sub-variants here that Steve will talk about here in a minute. And I'll just wrap up with 1 or 2 here, Steve. Isolation status, we were at a point in time where we had 259 students on campus in isolation. As of this morning, that's down to 1. We have 19 students currently in isolation. So the capacity there has worked very well. We go to the next one. We are monitoring very closely what's happening at every one of our peer institutions. They're talking to us, our academic year slightly ahead of some of our peer institutions. And so especially at places like Cornell and Emory, they were about 2 weeks behind us and had very close to the same experiences, and then tried to adapt some of the same, especially on our modifications on testing. I think the last one, Steve, here on the next one, going forward in the immediate future, we'll continue the frequency of our testing. Cam is going to talk about preparation and expansion. We're ready for this based on what the CDC will say about moving forward with a 3rd dose. And then, as you know, we've moved forward with flu vaccination for our students, and we'll be rolling that out for our faculty and staff next week. Steve, I think I turn it over to you at this point.
Great, thanks, Kyle. So there are a lot of opinions about what we ought to be doing in the COVID space, and I think that really comes from different experiences we all have and different perspectives. And so before I get started, I want to be really upfront with my perspective. And currently, I will be teaching 2 courses this semester. One of them is a graduate course of about 15, the other an undergraduate course of 20. I'm teaching in BioSci 154, which is just a little larger than a big school bus. And so I think a lot about how I deliver a great course and keep everybody safe at the same time. The second perspective I have is my wife and I dropped off our kid at Rutgers. She's a new freshman. And so I also think a lot about the student experience and how do we optimize the experience of our students while keeping everybody safe. And so when I think about what we ought to be doing in the COVID space, I come mainly from those 2 perspectives. So I think I want to tell a little story today about planning. There's been some questions about how we make decisions and where the data comes from. And so we started planning for the fall about a week after commencement in May last year. And as part of that, we engaged a modeling study, and part of that was in response to guidelines from the CDC for colleges and universities that came out on June 4th. And those guidelines suggested that for vaccinated populations of students, they shouldn't be required to mask or social distance or participate in surveillance testing. And so we really wanted to think deeply about this. As Kyle said, we were watching what was happening globally. And so we engaged a model that we had created a while ago and asked this pretty straightforward question: what's the impact of surveillance testing? And we also looked at quarantine on limiting infections in student populations that are 100% vaccinated. And I'll move hopefully quickly through this. All of it is published. It's up on the archive right now. And I'm happy to share that information with folks who are interested in the details. So let's see. Okay, so one of the big questions we had was about vaccine effectiveness, and particularly its effectiveness at preventing infections. And at the time, Pfizer and Moderna were reported to be 90% effective against infection, J&J about 66%, and I should say that each of these vaccines still remains highly effective at preventing severe disease. So what we did is we started off asking of our model, and this is an agent-based SEIR model, kind of a standard epidemiological model. What is the impact of surveillance if we have a 100% vaccinated student population and that the vaccines are 90% effective? And on the left, we're looking at all the assumptions we started with. And again, I don't want to get too deep into the weeds. It's all published and happy to discuss with those who are more technically oriented. But what we see here on the right in a couple of graphs is that in red, we're looking at student cases without testing. And we actually started with an initial condition of 5 out of 5,000 students being infected, and then asked what happens if we test in blue versus we don't test in red. And these bands are 95% confidence intervals, and what you see is you really can't distinguish between red and blue in this condition. And then the other thing that we varied was the outside prevalence, so the prevalence in the Durham community, 0.1%, 1% down here, and again, largely no difference between testing and not testing. And for us, this is what herd immunity looks like. We've heard a lot about herd immunity. But our big question is, what about variants? And at that time, we had just started seeing Delta, and we were mostly Alpha in the United States. But I pulled a slide off of a presentation that had been given at the CDC, and studies in other countries had suggested that various vaccines were less effective against some of the variants we're seeing here, Alpha and Beta, and then J&J against P2 from Brazil and Beta again, all the way down to 52% effectiveness. And so we took that model and said, okay, what happens? This is 90% again. What happens if we lower the vaccine efficiency to 75% here and 50% here. And what we found right away at 75% that not having surveillance testing made a substantial difference in the number of cases we were looking at. The y-axes here vary, so pay attention to that. And then as we go up to 1%, which is we're very close to that right now, we can start to see something that almost looks exponential. When you get down to 50% efficiency, we start to see exponential growth on campus. And the only reason the cases go down here is in the model that all the infected students become immune. And so essentially the disease has kind of burned through the population. So this made us very, very worried about what might happen for variants like Delta if the vaccine effectiveness got lower than 90%. We also studied quarantine and asked whether quarantines of segregating our exposed but not infected students for 10 to 14 days was any better at reducing the number of infections we saw than simply testing them at a higher cadence. And what we found, surprisingly, in these last two rows of this table is that quarantine wasn't any more effective than testing at a higher cadence. And so this is one of the other things that we investigated a little further in terms of policy. So not going to go through these this ridiculously complex slide. It's all again in this paper, but there's model architecture. These are the parameter estimates. Some of them came from publications. We fit some of the parameters in the model directly to infection data from Duke. So there was some Duke specificity to what we had found here. And again, this is all published and available. I'll also point people interested in modeling, all the data models code can be found on a GitLab. It's shown here. We're making that all available. So conclusions, so if vaccine effectiveness stays at 90%, then surveillance and these other mitigations really have a marginal impact on the number of infections in a fully vaccinated population. But if vaccine effectiveness drops below 75%, we can start to see a substantial impact on the number of cases we see, and that testing and mitigations again become more important. And then finally, increased testing cadence for exposures works as well as quarantine in our models. So what are the limitations? It's a model. So all models are wrong. Some models are useful. I think this has been a useful model. There are things that we didn't explicitly model, including symptomatic testing, which is something that's really important. We didn't model anything about vaccine effect on severity of illness or hospitalization. It's very clear that vaccines are still very good at preventing severe disease and hospitalizations. And one of the things I think that folks are debating is as the impact on illness and hospitalization drops, maybe we should have an increased tolerance for infection. And again, that's something that that is up for discussion. I think the caveat for me is that unvaccinated populations in our local community, as well as immunocompromised members of our Duke community, are something that we're really concerned about when we think about having too much tolerance for infections on campus. So much of what we found in this modeling exercise drove some of the policies and strategies that we developed for the fall way back in June. And as Kyle said, we were the only university that I knew of at that time that really committed to continue to test our vaccinated student populations. And it was a very, very small group. And certainly now many of our sister universities and institutions are now following suit. Real quickly, as Vince pointed out, I just wanted to that we're seeing a pretty substantial rates off campus of infection. Our statewide weekly incidence about 0.5%, Durham County about 0.3%, Wake County about 0.2%. And this is Duke's weekly incidence on campus, so substantially lower. What I want to point out is these numbers were computed from the New York Times COVID dashboard. the amount of testing we're doing at Duke is so much higher than what's happening statewide or in these other counties that these are a pretty severe underestimate of the cases that we're seeing, and this is a very accurate number. So Duke weekly incidence right now is well below what we're seeing off campus, and we're very, very proud of that. So as Kyle pointed out, again, we've been sequencing, and this is part of a statewide sequencing effort. Tom has been able to secure a grant from the state. We're participating as a part of a collaborative for various universities and institutions who are sequencing positives, as many as we can get, and then sharing that data with the state and with the CDC. And, above here, what we saw is alpha here in red take over fairly rapidly, and then extreme rapid takeover by delta. And then on the bottom here, I just want to point out that we continue to track pretty much 100% delta on campus, but we're also tracking some of the sublineages of delta here to make sure that we're not seeing any of them substantially expand over time. And with that, I'm going to turn it over to Tom.
Thanks, Steve, and thank you all for opportunity to present today. So I want to take you back to the early summer of 2020 when the program was sort of being conceptualized, and we were thinking about what the guiding principles had to be. And so what I'm going to talk about is asymptomatic testing, asymptomatic surveillance system compared to that what is done in a clinical system for the symptomatics. And my career started early in the HIV days, and we had many of the same challenges then as we do now. We did not have the resources that were needed for testing and treatment and you name it. And we had to be innovative and come up with some new approaches to meet all of those challenges. So for an asymptomatic testing system, some of the principles that we set out on is one is we didn't want to compromise the clinical system. We wanted to have a scalable system. We didn't know where we were going. Were we going to need 1,000 tests per day or 5,000 tests per day, which we got to 5,000 tests per day pretty quickly. We wanted to have a system that was independent of supply chain challenges. It would not have helped us to develop a system that we started and then 6 weeks into it find out that we could not guarantee supply chain and would be out of business. And then the last part of it is we wanted to have a rapid turnaround time. If you're doing asymptomatic surveillance testing, you have to be quick. If you're turning results around in 3 days or 4 days, you've already had individuals walking around that are infected, that are transmitting, and sort of it's so what? Why do it at that point? You have to be able to do this in a rapid turnaround time. So those were some of the guiding principles that we set out to develop in our system, in our testing system. I don't have time to go into details of it, but I'll point out a few of the important parts of what we do. But if you go to the CDC's MMWR, the CDC did contact us last year, and they had heard about our program, and we were featured in an MMWR article, and it's all the details. And then later in next slide, Steve. Later in 2020, I participated in National Academy of Sciences workshop, and that ended up with this article providing advice to other universities on testing programs. Next slide. So one of the hallmarks of our system is what some of you that have labs call a home brew. This is a laboratory developed testing system that we set up, and we did this early on in the pandemic because if you make the analogy to HIV, knowing viral copy matters. And we thought, and my team thought, that being able to estimate the viral copy was going to be something clinically important. And we've done a number of studies with the ICU teams and others to show that there is some validity to viral load. So we developed this system, and you can see that we can have almost 100% in detection down to 31 copies. That's a very sensitive assay for picking up something that we're doing. And we built these validation panels, and we ran through them, and we were confident that we had a platform that was scalable for us, that we could deploy for this need. For those of you that know PCR, this is old-fashioned PCR, two-step PCR. So the secret why it's scalable, no one wants slow reagents today that take 10 hours or 12 hours. They all want the rapid PCR. So when we were developing this, we were absolutely certain that we could have supply chain that would guarantee our ability to meet the demands that we were thinking we would need. Next slide. So the other part of it is pooling. If you wanted to test, 15,000 samples in one day, it would be very hard and very expensive. So one of the workarounds to do that is to do what's called pool testing. And pool testing is very simple, is you build a pool of a couple samples, you test, and if you get I guess my pointer won't work here, but if you see that red dot in that one top test tube, yeah, thank you, Steve. That is one sample lighting up in that pool. And what you then do is you go split that pool into the individual samples, and that is we've had them sitting in a refrigerator from when they came in from the sample acquisition part, and then we test them individually to show which member of that pool is positive. Next slide. So when you build pools, you have to make sure that you have sensitivity. And when we were conceptualizing this project last year, we were thinking, well, what number would we have to test on a daily basis? And we said, well, maybe it's this number. Maybe. So we settled out on a couple different pool sizes, pools of 5, pools of 10, and pools of 20. And what we wanted to make sure that if we had to go up to high pool numbers, pools of 20, that we had sensitivity. So on the right side, you will see what the sensitivity looks like for our in-house system. And you'll see that we can go up to a pool of 20. We started out with pools of 5 last summer, and we migrated in the early spring of this year into pools of 8. And that was basically to accommodate a higher volume of testing on a per day basis. On the left-hand side, you're seeing data for an Abbott M2000. That's a clinical platform that we use. That's used in a lot of laboratories. And you will see there that that system has a sensitivity of 100% up to a pool of 10. So the bottom line is our in-house system that we use for the first screen of testing is highly sensitive. And I don't have time to show you, but the data it's highly, has high specificity also. Next slide. This is just shows you, it's a little bit out of date, the overall numbers, but I think we're up to about 650,000 tests we've done since inception of the program. And this just shows you how different points of the time we had a little bit of a plateau in testing needs. Campus was quiet, things were good, and then we had to rapidly start escalating again. Next slide. This one is also a little bit out of date, but this is just a cumulative number of positives. It just shows you the trend. You all know it. You've been living it when campus was calm and quiet, and then we had the surges, and you can see where the numbers come on. Next slide. So this is a summary slide. Basically, it puts it all together, what we do on a day-to-day basis. So we rely on a lot of information coming into the modeling team. So testing is a barometer of what's going on in your behavior in your campus environment or whatever you're testing. And it's important to not just pick out a few people to test, but to have some sort of a modeling system or metrics to pick out who's going to be tested on any one day. And that's what Steve's team and others work very hard to do on a day-to-day basis. Then there's a whole team, operational team there that has to schedule this. They send the students a notice. They get it on their phone. They know they have to present and have a sample provided. Then it comes over to our laboratory, and we build the pools. We use robots to make these pools for us. We can go through several thousand pools, making pools, building them in about a 3-hour period, 4-hour period, and then they go on to the testing platforms. We run the lab 3 shifts a day so we can work with rapid turnaround times. That was a challenge, adding it, when you're a lab such as ours, a research and discovery team, bringing on a night crew like a clinical lab took a little time to get that bandwidth up, but we got it up. And then we're fortunate, we are also a clinical and CAP accredited laboratory. So we have a number of clinical platforms in our laboratory. So what we do is after we have a positive pool, we deconvolute it and we bring it over to one of our clinical platforms and we start testing to see who's positive. So at the end of, I think we're probably on about an 18-hour to 24-hour turnaround time now from the time we get the sample. We have sent a result back through the electronic records into student health or employee health, where they then have what I refer to as a medically actionable result. They can institute contact tracing, they can institute any other things that they need to do with a typical medically actionable CLIA accreditation result. So that's sort of a summary of how we do it. I'd be happy to talk with you offline if people have questions about it more, or you can refer to the MMWR for more details on the system. But thank you, and I think Cam is next. I think that was my last slide.
Yeah, hey, thanks, Tom. And look, I really appreciate the chance to discuss this with everyone too. Thank you for being patient with our last 18 months. Heck. Maybe before I get into the few bullet points that I'm going to talk about, I did want to emphasize one of the things that we really tried to do that Tom and Steve both hit on in their diagrams, which was to try and actively learn as we saw positive cases coming through, as we saw symptomatic kids coming through in real time, where to modify and direct testing to in ways that would reflect where cases were occurring, and to learn, frankly, from that in terms of sort of actionable items to offer different mitigation techniques to. And so much of that was real time. I think Steve and actually many of the folk in both contact tracing and student health deserve the heavy credit for that, because it really did give us a visibility on how to apply this testing in a way that was unique to all of our student groups, because their risk has been different. We've seen different risks on campus and off, and I'll get a little bit to that. One of the things that we reassuringly have not seen still to this day, and I think this is perhaps the most relevant for this group, is a classroom risk through both the sequencing methods of tracing that Steve highlighted, and actually then the simply laborious man hours of picking up the phone and speaking to all these kids. We've certainly had a very good and I think well-colored menu now of how people have transmitted to each other. And for the most, and to this day, we don't have instituted cases where we've seen that occur within the classroom. Now, that's been in a pretty mitigated situation. You know, you guys have all gone through scenarios, certainly through the last calendar year when it wasn't in person, but that's held true reassuringly as we've moved into classrooms, both in the early phases of last semester and now actually this semester as well. What's also been true is that we could take that same sort of data and apply that functionally for my role in athletics, for example. We didn't see on-field transmissions. And almost the parallels to me have been really helpful to sort of visualize, is that it's not been the daily activities of what our students have been doing. It might have been what they then went and did after hours, or what's been happening in the downtown or in their bar or their apartment complex, or perhaps in our meal halls, and we've had to make adjustments. But those sorts of things have been, I think, very helpful for us to then come back and blend both the phylogenetics and the contact trace to sort of get a better, really clear picture of that. And I think we probably have a clearer view than most. Kyle, I'm not sure if you're in charge, but you can click an extra, yeah. So I wanted to highlight something, that the other parallel that we've been able to watch here is in fact what happens in the healthcare system. And I guess I've had really a privilege to watch sort of how my colleagues in infection control in the hospital have handled their risk, or our risk, which has been, kind of unique for other reasons. And still the graph here that I think has been the most impactful to me was we took a very early decision compared to other colleagues to instigate indoor mask requirements. And this was done this graph now extends well beyond, but this is a section of the middle of last year. The red line being employees that were becoming sick, where we could clearly document their exposure was at work, either from patients or peers. The yellow and green line being either clearly documented out of work exposure, or ones where we couldn't quite pin it down. But what you can see is the final line there. I appreciate this may be a bit small to read. Again, this is published, and I can share the link if folks need, is that our community rates where our staff were then leaving and taking their mask off, in fact, continue to exactly mirror the community transmission rates. But when we were in congregate, close-knit, intense exposure situations at work, the mask made a profound difference in terms of reducing our exposures of our own staff. And I think this has been exactly the parallel that has occurred on the campus, is that we've tried hard to use sort of this data to anchor decisions on masking wherever we could. And you'll see that that'll be one of the last things that I think we pull back on as things hopefully ease away. I can certainly go into more detail about other mitigation activities if folks want. Kyle asked me to talk a little bit here about sort of, I guess, projecting forward what this means. We are nearly 100% vaccinated, which I agree is an extraordinary effort. That isn't a static number, though. That's moving, as people realize. And probably as we speak, I was waiting for tweets from the CDC's panel to look at how they interpret boosters that will be relevant for many of us on this call. What we know so far is already, if you're immunosuppressed yourself, and many of our faculty and certainly some of our students are, that you're already cleared for a third dose. We know that that's helpful in those groups. But I do think our expectation is that we'll be coming back to both students and particularly older adults who work on campus and live here and work here, to suggest very soon that boosters are relevant for people over the age of 65, relevant for folks who are on the front line of healthcare, and then potentially relevant for students and teachers, although I think that interpretation of how the FDA thinks about institutions is what will be sort of guided on there. And I can get into the weeds of that if folks want. Steve mentioned he just dropped one of his kids off at college. My two kids are at the polar opposite end of the spectrum. They're both in elementary school. So I sort of view this from quite a different spectrum, but I also view the FDA's decision-making on vaccines for kids, and I'm sure many of you are in this same boat. We have had better visibility on childhood vaccination expectations as of this week, with some really reassuring information from Pfizer that it looks very effective and safe in our 5 to 11-year-old age bracket. As you know, it's already approved for 12 and above. People often ask sort of when do we expect that will be released? I think knowing the pathway of FDA submission, FDA approval, CDC approval, current projections would sort of be towards the latter half of October or early November would be the earliest. But that's quicker than where we might have projected if you had asked me the question 3 or 4 months ago. So I think for those of us who have elementary or middle school aged family members, that will also be a real weight off our shoulders to get our kids protected here as well. I'm happy to pause there. I think really we also wanted to let people have plenty of chance to ask questions. So again, thanks for the opportunity.
Thank you, Kyle, Steve, Tom, and Cam. Really appreciate you giving us a deep dive into what has gone into the planning for the semester with modeling, testing, mitigation measures, and the importance of masking for all of us. We have a few minutes that we can have questions, and if for those who can stay a bit longer, we're happy to keep going if there are a number of questions, but we also recognize that many of you may need to jump off. So if you have any questions, use the raise hand function, and that will make it easy for us to, for at least me to call on you. Yes, I am going to start with, Dr. Cohn. Harvey, do you want to jump in first?
Yeah, just a quick question, I hope. How do you anticipate handling Cameron Indoor Stadium crowds in the fall for men's basketball? I'm thinking, sounds hard to distance.
Harvey, that question has been at the forefront of many people's mind, I can guarantee. Look, you think of Cameron and you think of what makes that a great stadium. What is it? It's densely packed. It's everyone's yelling, and it's a small, dense stadium. That's what makes it great. But that's also not ideal in this situation. So I know we've already been going back and sort of reevaluating the ventilation system within that, making sure we can do what we can there. It's not finalized yet, but many athletics departments across the country are evaluating basketball within the context of masking, vaccination, and testing. And without sort of spilling too many beans, I think we'll be very much reviewing those three mitigation techniques for games. Because at the end of the day, it's a close-packed stadium. And what worked for the players last year up until March Madness was the fact that they were masked and spaced, and then they didn't have the chance to be vaccinated. Whereas I think there's a really good opportunity here for letting people in who are vaccinated. We should lead in that regard.
Thank you. Jolie?
Yes, thank you. So first of all, I just wanted to thank you for the presentation and also for all of this work. And I have to say, over the past few weeks, I teach 2 classes in person. They're both quite filled. And I felt my blood pressure dropping week over week as we've seen the numbers come down and how quickly the administration responded when they went up. And anyway, I just, like, from a teaching perspective, I wanted to thank you all for how much better this year has been than we thought it might be. 2 questions that maybe are kind of first world problem type questions, but one is about whether there's any plans for maybe closing the restrictions for, or closing the exceptions for exemptions to getting the vaccine in some of the smaller departments and smaller spaces. Having unvaccinated, particularly staff, because they're there all the time, has just sort of limited the extent to which we feel like we can kind of fully come back. And I know there's ethical and legal questions at foot there, but I'm just wondering if that's on the table. And then, and this is a kind of crystal ball question, but for those of us that are thinking about large in-person events potentially in the spring, is there a timeline by which we should be making decisions around those kinds of things? Thank you.
I mean, I can answer the first part. I'll leave maybe the large function question somewhat later, because we've grappled with that exemption question for a decade now with flu vaccines across the hospital. And we've had a medical task force. In fact, we've needed many because of the size of this year's program to review medical exemptions, and they've been fairly straightforward with COVID, to be honest. Religious exemptions have always been a more difficult one to navigate because, in fact, there is EEOC guidance, excuse me, on the fact that it is anticipated that institutions will allow flexibility, and I'm going to not get the wording exactly correctly, but strongly held beliefs, and then it goes on. Sincerely strongly held beliefs, I think, is the exact phrase. And so it leaves open to the legal interpretation the word sincere, and it leaves open to the recognition that it doesn't have to be an organized religion if that's your strongly held belief. And that has some legal precedent, even though people have debated the exact context. And so that has always left us in a position where we felt the right answer was to give people the breadth of what they felt was important for them. As their sincerely held belief, strongly held belief. But you can clearly, you're raising to a point which has been grieving to me, frankly, for many years, which is that allows flexibility that, frankly, is, I'm sure, not ideal medically, and probably not the original intent of the crafters of said language. And I'll leave it at that. If someone else would like to talk about this.
Yeah, I might be able to hop in on the second question. I mean, certainly large gatherings present an increased risk, and there are ways to mitigate that risk. Masking, being outdoors, these are all things that we've learned and relearned over time. In terms of predicting, and you said crystal ball, I think it's probably there. And there's a very large group of people trying to model transmissions and positives nationwide. And there's actually a site on the CDC where you can see all the modeling predictions. And oddly enough, they look like the predictions for where a hurricane's going to hit when it's just off the coast of Africa. So they're all over the place. And oddly enough, the best predictor is the average of all of the models. Now that prediction still is only good a few weeks out. And this has been a great frustration for all of us, which is we don't have a good way of predicting what's going to happen more than 2-3 weeks out. And so that makes it very difficult to plan for events and other things. And so I don't have a great answer, but as we know right now, the flexibility is key, I think, under these conditions.
Thank you. So I'm going to follow the example of pooling, the testing, and I'm going to pool 3 hands up and just have them ask their questions and then let whoever wants to respond. So I see Edna Nine, hopefully I'm pronouncing your name correctly, and Trina. And I would just also have you introduce yourselves and ask your questions.
So hi, I'm Edna Andrews. I'm the director of the Focus program, and I've been teaching in the classroom 5 days a week since fall of 2020. So I'm actually not going to ask you a question. I'm going to say thank you, because last year, while I felt reasonably comfortable in the fall, by the spring, waiting to get vaccinated, it became a little tenser for me personally in my head. But I have been blessed, and your protocols are wonderful, because, well, I'm a living example in my students, and the Focus program with 500 plus in the classroom. I want to thank you guys for everything you've done in this wonderful presentation. And I think on behalf of so many of us that are not here today, just wanted to let you know, thank you. And thank you for sharing the information, and please keep doing that. Thanks.
Hi, I'm Mina Chitinkarandel from Statistical Science. So my question is that this has been a wonderful presentation, and I've been to flavors of this presentation, I feel like, over the last couple of weeks, which has been great, because when the first emails from Sally came and we were reading there's no classroom transmission, as a statistician, the question I asked is, how do we know? So it's really nice to hear the how. My question is, how are we communicating this, the scientific part of this, to our students, because they are also curious? It's possible I'm dealing with a group of students who are studying statistics, so they're additionally curious. But what I hear from the undergraduate body is they're thankful they don't have to be on Zoom 24/7, but they are curious. And I don't think, to my knowledge, they haven't had the privilege of being in these meetings. And maybe I don't know, that's also possible. But yeah, I guess what's the plan for communicating some of this inward into the university at the level that our undergraduates will be able to kind of appreciate as well?
Sally, do you want to jump in on this one too?
Sure, a couple things. One is, we're gonna do a sort of more, probably not as data intensive that would satisfy statisticians, but a sort of brief sort of interview with Steve, and Greg Ray's been doing the sequencing, et cetera. So we'll cover, at least in lay terms, some of this. Erica, I guess I would ask you, we've taped this part of it. We talked about making it available to all faculty under NetID, and I was going to put that out in a note to all faculty. I don't see any reason not, we could discuss with Kyle and others after, but I think certainly the scientific portion of the talk, I think, could be more broadly available, and also to send the link around to Steve's paper, I think, is another thing. So I think we could work this in some way into the student messaging as well. And, we'll definitely talk with, Mary Pat and Gary about how we do that.
And I realize I just skipped over Trina, so I'll let Trina ask her question and then have anyone else who wants to respond.
If I can just add one thing to what Sally said, I think, sorry to catch you there, Trina, I really am, but on the previous thing, like we have probably 3 or 4 very public MMWRs discussing exactly what's happened in a way that's visible to everyone, sort of either half written or well underway, both within Duke and Duke's collaboration with other folk. And that should be absolutely presented to the students, because it is their data, and they absolutely deserve to hear this. So I'm so glad that question came up. Sorry, Trina. Answer it.
Hi, I think this is probably a non-issue, but it would be wonderful to receive confirmation that it's a non-issue. So I'm teaching 50 students in the law school. And one of my students sent me an email last night basically saying that he had tested positive. And we proceeded to talk about how he would access the material. But for the email being sent to me, right, I would not have known that the student had tested positive. We were all in the classroom for 90 minutes yesterday, socially distancing with masks, right? And we were back there today minus the student. I wasn't overly concerned because I've been told repeatedly that the risk of classroom transmission is very small. But if I were immunosuppressed, or if I had a child who were unvaccinated and I was coming home to that person, I think I'd want to know that someone was positive in a closed setting in which I had spent some significant amount of time. Could you tell us whether our protocols are adequate, keeping in mind privacy concerns, right? To make sure that people who might be at higher risk or who may have a family member who is at higher risk would know that they've been, in an enclosed space with someone who has tested positive, even if the risk of transmission is low.
Yeah, I mean, I think this is a great question, and it exactly comes to the to why our colleagues who and in student health and some of the contact tracing folk need a lot of the credit here. We've tried to dance a balance here, haven't you? Because exactly the other comment you mentioned is health privacy against sort of recognition of public health need to trace individuals. And there's a very fine line in public health that allows you to have, in fact, we've been lucky to have a dual relationship with not only student health contact tracing, but all contact tracing that the health department then tries to do as well. And then we sort of blend those together in a complementary way to say, look, what sort of exposures here might have reached the threshold where we need to contact people for their, and to do it in a way that helps us minimize transmission, but also keeps privacy. And so that, I think it's been successful so far because we've seen the numbers come back down and we haven't seen inadvertent transmissions that we have not anticipated or not expected. And so, is it going to leave everyone aware of all of the cases that are occurring in their classroom? Actually, it won't by intention. I'm glad that student, to be honest, had the wherewithal to come and say, hey, look, I'm not going to be in the class. I mean, that's important for other reasons, clearly. But that you can imagine that's a pretty delicate balance between student health calling that individual, talking through what they've done, where they've been, what did the class look like? Was it an indoor, outdoor class? Were they on the ship in the Marine Lab, for example, with, living in each other's back pocket? We've had all sorts of permutations of that. And then to expect that the county health department will probably do the same thing and ask many similar questions. And actually our students have had different answers sometimes to both, as questions have been posed in different ways, or they've felt more or less comfortable to answer questions. And so I think they've worked pretty complementarily to help reassure me. And at the end of the day, I go back to the data that we have in our healthcare system as well, which says, like, in a mask situation, I don't know when I'm not told, for example, in the hospital when my colleague tests sick, because that's his or her information. I'm told if I have an exposure that's significant, and that's what I have banked on. But I appreciate your question, because I think it is, that's when it's reassuring for me that my kids will be vaccinated. And that's when it'll be reassuring to me when, I've had a chance to have a booster and we've all gone through these phases where we also know that, myself and everyone around me is also protected in case those things are not picked up. But for the most part, they've actually been really accurate.
Cam, if I just can add one thing, I think that has helped some people in terms of reassurance is really to, re-emphasize that anybody can enter the regular surveillance testing program. So I think, for folks teaching, there's so many sites on campus and around, to just incorporate it into the routine has, I'm not saying that everyone has to do that. It's just reassuring for a lot of folks to be able to do that.
Okay, I know we're almost 10 minutes over, and I don't see any more hands up, but I really again want to thank everyone, Kyle, Steve, Tom, Cam, just sharing your experience and also being willing to answer questions whenever we have questions that we send to you. And so I want to encourage members, of the council, when there are concerns that come up, to reach out, because we've been in constant, in conversation and trying to get responses conveyed in different ways, through, messaging that comes out of Sally's office, or having such event, such presentations at Academic Council. So again, I really welcome suggestions. And with that, again, to thank the presenters and to thank everyone for joining the first Academic Council meeting today. If there are questions, again, the email is acouncil@duke.edu. Our next meeting is on October 21st. Hoping that we may be able to meet in person in our usual location, which is in Westbrook, in the Divinity School. We will be masked if that happens. And otherwise, hope that everybody has a really good evening, and maybe I will see some of you tomorrow at the dedication ceremony. Thank you.
Bye.
Thank you.
Bye.